Hello, my name is Christopher Modi. I'm Director of Clinical Services for Heidelberg Engineering Limited here in the UK. Today I'd like to talk to you about OCT angiography. It's a very new technology. It's very clearly embryonic in terms of its technical development, but also in terms of its clinical utility and our understanding of how to deploy this technology to its maximum effect. So I think it's important that we sort of dismantle some of the misconceptions about the technology and then start to introduce some new standards that may be required in terms of utilizing this. One of the questions that have been raised by many of our customers has been, why is it taking Heidelberg Engineering so long to develop this technology? Well, we were informed by our owner, Christoph Schurz, complex questions require complex solutions, and this takes time. And I think this will become apparent when we start to explore OCT angiography. When we're thinking about angiographic imaging, fluorescein angiography has been described as the gold standard, and it's a term that I hear used on many occasions. But what do we actually mean by gold standard? So let's perhaps explore that a little bit more fully. OCT is quite clearly redefined standards for imaging, and the widespread use of OCT for structural assessment of the eye has now become commonplace in the standard of care. But what about OCT angiography? Is that going to be a new standard and introduce new frontiers for assessment of patients? So let's try and explore that as well. I attended a review session at ARVO about 3 years ago looking at the IVAN study, which is one of the treatment trials for neovascular AMD. And one of the moderators of that session turned around and said that, of course, fluorescein angiographic imaging is the gold standard for diagnosis and treatment decision-making in neovascular AMD. And everybody in the audience nodded wisely in agreement. Of course it is. Which rather leads the question, so what exactly is a gold standard? Well, actually, it comes from the 1930s during the Depression, where it was actually a means of identifying whether or not there was sufficient gold in the Federal Reserves to support a currency, and therefore did it have the appropriate face value. Obviously now it's come to mean just a thing of superior quality. So what exactly is the gold standard for fluorescein angiography? Is that a 30-degree field of view? Is that a 55-degree field of view? An ultra-wide field image? Stereo image? Or even a dynamic video? What exactly is the gold standard for angiography? Well, if we consider what is accepted by the international reading centres, that's a 30-degree stereo field. And that seems to be the standard by which all clinical trial images are assessed. So I guess that's our standard for fluorescein angiography. But at that same meeting, the co-moderator of the session turned around and said, but is fluorescein angiography still the gold standard? Most of our diagnostic treatment and decision-making is based upon OCT assessment of the eye. So is angiography still the gold standard? That's certainly true in neovascular AMD. The vast majority of treatment decisions are based on structural assessment. So we're looking for the presence or absence of subretinal fluid, intraretinal fluid, evidence of increased retinal thickening, intraretinal exudate, and hemorrhage, and subretinal hyperreflective material. All of these are structural assessments of the eye based on OCT, and certainly progression analysis with repeat OCT scans has been an essential part of that management process. So all of the things that we described are structural changes. None of them reflect OCT. So once again, has OCT redefined the gold standards for patient assessment? So what about OCT angiography? Well, certainly the diagnostic specificity and sensitivity of these tests are reasonably high, but admittedly these have only been done using relatively small cohort studies. But the presence or absence of neovascular complexes can be seen very, very clearly on OCTA images, and the anatomical location of the vascular lesions can be very carefully described in relation to the surrounding anatomy. So again, fairly accurate classification is possible. So will OCTA become the new standard? Now, there are lots of limitations that we hear about OCT angiography. It doesn't show dye leakage, pooling or staining. We can't assess the integrity of the blood-retinal barrier. So are these shortcomings of OCTA that mean that it will not ultimately take on the same role as fluorescein angiography? Well, probably the simplest description of that is when we think about Q-tips. The one thing that we all know that we should never do with Q-tips is clean our ears. The one reason that we use Q-tips is to clean our ears. So regardless of whether the item is suitable or not, if it has a clinical utility, it will almost certainly be adopted. So if we're going to consider retinal angiography using OCT, we need to consider what are the limitations that are presented to us by the anatomy that we're trying to visualize, and then also, and very importantly, the physiology that we're trying to record. What we're doing here is metabolic imaging. It's not structural imaging, and we need to redefine our understanding. The challenge within the eye is to achieve nutrition of the tissues without compromising visual performance. In any other tissue within the body that has a high metabolic demand, then we simply increase the size or number of the blood vessels to increase blood flow to the tissue to meet that particular requirement. In the eye, if we do that, then we can potentially run the risk of compromising visual performance. The retinal vasculature overlies the photoreceptors, therefore if we increase the density or diameter of the blood vessels, then we run the risk of compromising visual performance. So we have to have a very specially adapted microvascular structure to meet the needs of the retinal circulation. What can change, therefore, then is the space between the capillaries, the density of the capillaries, and the looping patterns of the capillaries to increase flow to a given tissue. Avascular tissue, we see an oxygen diffusion gradient appearing. So the deep vascular plexus of the retina will perfuse the avascular tissue below in the outer nuclear layer and the photoreceptors. Equally see perfusion from the choroidal capillaries as well. This is typified by the appearance of the foveal avascular zone, obviously avascular tissue, where we have just purely the photoreceptors exposed to incoming light, and therefore we can achieve the highest resolution in terms of vision or visual performance. When visualizing the foveal arcade using fluorescein angiography, clinicians are trying to identify an interruption in a ring of blood vessels encircling the fovea. Dropout of a single capillary can have a significant impact in terms of visual performance for the patient, and therefore OCT angiography has to be able to replicate the same degree of sensitivity in terms of detecting those changes if it's going to be routinely deployed for assessing macular ischemia. In terms of imaging in the eye, then we have a number of challenges to overcome, and I think the electron microscope image that we can see in the slide shows some of the challenges that we're facing. The retinal microvasculature is a small but highly dense retinal capillary plexus. The choroidal capillaries, however, are very, very tiny, and even with electron microscopy imaging, we're struggling to visualize this fine vascular structure. Choroidal capillaries are currently outside of the range of any commercial OCTA device. Yes, we can record an impression of flow within a carpet or mat within the location of the choriocapillaris, but we cannot record flow within individual capillaries. What we are able to do, though, is to visualize neovascular complex. So we can see abnormal vascular components within the choroid, and these are very clearly visible as they have a larger diameter. So the goal for OCT angiography then is to record visible flow within a static transparent tissue. When we consider a basic ophthalmoscopic image, we're able to visualize large arterioles, venules. We're able to visualize small capillaries and down to really quite small bifurcations. And it's even possible to visualize the perifoveal capillaries and get an impression of the location of the foveal avascular zone, even with high-resolution fundus imaging. Fluorescein angiography has always allowed us to visualize the microvascular flow, but this is an invasive procedure with no morbidity and mortality. But it gives us exquisite recordings of the microvasculature of the retina, and the ability to identify the location of the foveal arcade has allowed clinicians to get an indication of visual performance or potential in a patient who might be undergoing treatment. The high metabolic demand of the retina means that if we compromise circulation, then we see very significant and very rapid changes within the structure of the retina. In this case of a patient with retinal arterial occlusion, we can see lots of infarcted retina and evidence of inner retinal edema. In an acute vascular occlusion, once again, we can see areas of non-perfusion and associated atrophic change within the retina. And these changes occur very rapidly, and this indicates again a high level of metabolic demand of this tissue. When it comes to imaging the microvascular structure, angiography has provided us with the gold standard, and it allowed us to see very, very small capillary structure. But it's OCT that's provided us with unrivaled images of retinal structure. As we start to look more closely into the OCT image, we can start to visualize evidence of the microvascular structure. And these are indicated by small hyperreflective dots. Blood is reflective to infrared light, which is used to generate the OCT image, and we see small reflective structures within the ganglion cell layer, at the outer border of the inner plexiform, and the outer border of the inner nuclear layer. When we visualize the OCT reflectance image then as an en-face image, we're able to see a reflective pattern of the blood vessel walls and the blood vessels. But it's OCT angiography that allows us to see flow and vessel detail with exquisite detail. What we're doing with this technique is recording the movement of erythrocytes in retinal blood vessels. This flow is non-linear, it's irregular, and we see choking and congestion within retinal capillaries. This means that the flow is not consistent, and therefore we need a much more sophisticated approach in terms of analyzing blood flow using OCT. Within the retina, there are 4 vascular plexus. These are located in the retinal nerve fiber layer, the ganglion cell layer, at the outer border of the inner plexiform, and at the outer border of the inner nuclear layer. Each of these retinal capillary plexus has an average diameter in the blood vessels of approximately 8 microns. When we look at the blood vessels in the choriocapillaris, we're looking at blood vessels that are approximately 6 microns in diameter. And of course, in these measurements, we're including the blood vessel wall. What we're trying to do, though, is record the blood flow within the blood vessels, so we need to exclude that from our assessment. So we're looking at an average capillary diameter of about 7 microns for blood flow in the retina and about 5 to 6 microns in the choroidal capillaries. Each of the blood vessel patterns has a unique architecture, and these are specific to the metabolic demands of those particular tissues. In the retinal nerve fiber layer, we see an arcuate distribution to the retinal nerve fiber layer capillaries. Within the ganglion cell layer, we see deep looping vascular plexus. And at the outer border of the inner plexiform and at the outer border of the inner nuclear layer, again we see a single blood vessel thick capillary plexus. At the outer border of the inner nuclear layer, the capillaries take on a very classical floret type pattern. And sometimes it's possible to visualize vertical communications between the vascular plexus. So this represents a significant challenge for any body trying to image the retinal microvasculature using OCT. We must image retinal capillaries with a very high resolution. We're trying to record blood flow within retinal capillaries that are in close proximity to one another. In order to ensure that we record separate flow signals in separate capillaries means we need to use a minimum resolution that exceeds the diameter of the blood flow that we're trying to record. If we use a high resolution small pixel sample, then we can record separate flow within the separate blood vessels. If the resolution is too low, we run the risk of merging the blood flow from parallel blood vessels and therefore not recording separate flow. If we're going to move on to quantify blood flow within the eye, particularly the density or perfusion of retinal structures, then we need to be able to be sure that we're isolating separate retinal capillaries. The minimum resolution, therefore, we can work with for routine clinical application is approximately 11 microns per pixels as a lateral resolution. If we're thinking about quantifying retinal blood flow and capillary perfusion, then we need to be thinking about using a higher resolution close to 6 microns per pixel. Going forward, what does this actually mean? If we have high resolution images, we get a crisper image. We're able to clearly delineate the separate vascular structures and the blood flow within them. We can see the branching points more clearly, and we can even see small microvascular loops. And of course, this needs to be the foundation for any future analysis of these images. In terms of identifying blood flow within images, it's important that we are able to isolate flow. If we think of the term angiography, what does it actually mean? Angio means pertaining to blood, and graphos means picture. So we're producing a picture of blood vessels or blood flow. We therefore need to try and isolate flow within our images. In order to perform an OCT angiography scan, we perform a very high density volume scan. At each B-scan location, we take multiple samples to record the changing appearance of that location. What we're trying to do is to record the movement of red blood cells as they pass through the retinal capillaries. And therefore we're looking for change within consecutive scans. If we're to identify this effectively, we need to work out exactly what it is we're trying to achieve. We're either trying to identify presence of flow, in which case that needs to have one value, or we're trying to identify structure, in which case it should have a lower value. With the approach that we've taken at Heidelberg Engineering, we're using a simple binary display. It's either flow or it's structure. It's black or it's white. Okay? And there is little or no structural component within our OCT angiography images. The basic principle is that we take multiple B scans at the same location. On each subsequent B scan, we'll identify small changes occurring in the reflectance pattern, which will correlate to the movement of red blood cells in capillaries. If we registrate these images and remove all bulk movement from them, we can reliably record flow at the same location. So how do we go about analysing the results? Well, if we look at a series of B scans over a period of time, and then we look at how the structure changes, we see very little in the way of fluctuation in the signal that we see from structure over a period of time. And this gives us a very narrow normal distribution. By comparison, if we then start to look at the same change that we see as a result of blood flow over the same period of time, we see a much greater amplitude or variation in the intensity of the signal. And this produces a very different distribution. When we compare the two distributions with one another, it's very easy to discriminate flow from structure. And we have a very high certainty of being able to isolate flow from our OCTA signal. When we then look at the B-scan image, we can then overlay the location of the blood flow and create an OCT angiography B-scan. So by taking this probability approach, we get a high discrimination between tissue and flow. Historically, for OCT angiography, we've been using decorrelation algorithms. And the problem with this approach is that it produces a lower contrast in image, and we see much more overlap between the signal that is generated between structure and that that's being generated by flow. And we see this lower contrast image, and we get to a point in the middle where we see a greater degree of uncertainty. Am I looking at tissue, or am I looking signal derived by flow? Basically what we're doing is taking a threshold and setting an upper and lower limit, and then assigning grey values to the elements in between. Essentially, with a decorrelation algorithm, we establish a range for values of flow. Within that range, we assign grey values, which can range, say, from 0 to 256, and we would then display a range of values for flow. Problem is that at either end of the spectrum, we can be fairly sure that we're looking at either flow or tissue, but the closer we get to the middle of that range, the less discrimination we have between structure and flow, and therefore it's not always possible to identify flow in the smallest of retinal capillaries. So let's take a look at this multisampling approach. So essentially what we have here is a B-scan image. Eye tracking has been enabled, and we can see that most bulk movement from the scan has been removed. Within the yellow circle, we can see an area where we're seeing change. This is derived from blood flow. Within the blue circle, we can see change defined by tissue. At the moment, we're just comparing two consecutive scans. As we increase the number of scans that we're reviewing, it becomes much more straightforward to visualize the degree of change that we're seeing within the image. And as we approached to a point of 7 samples, we can now quite clearly discriminate a large degree of change where we're seeing blood flow and a very small degree of change where we're seeing change within the static tissue. So both signals are changing with time, but the amplitude of change that we're visualizing from blood flow is much greater than that we're seeing from tissue. Small vessels can be easily concealed within this movement, so eye tracking is essential if we're going to identify flow within blood vessels. And again, the choice of algorithm to then subsequently analyze this change within the image is absolutely essential. Tracking is crucial, and if we're going to identify this very, very fine microvascular flow. The signal sent through a decorrelation algorithm, on the other hand, produces this very low contrast image, and therefore our ability to identify areas of small levels of flow is very, very challenging. And it may be insufficient to identify flow in small capillaries. So this sophisticated probabilistic approach produces a much higher contrast image with a much greater discrimination between structure and flow. We then look at the B-scan image again, and we can now identify areas where we've got blood flow, where we've got movement within the static tissue. It's flow or it's not. It's very, very simple. We can then start to color code and isolate the flow within the B-scan, and very accurately then start to produce high-resolution transverse section OCTA images. It's flow or it's not. It's very simple. This image of a patient with proliferative retinopathy explains the principle very nicely. At the top, we can see the combined OCTA structure and flow image. We can see the fundus image of a patient with neovascularization elsewhere, and the two images below show the B-scan structure and the flow that's been isolated from the structural information. Quite different appearance in the two images. The next challenge then is to consider the field of view. Up until this point of time, the field of view available in OCTA devices has been relatively small. We've been talking about a 10 by 10 degree field of view, which really means we can only assess the perifoveal structures with any degree of success. New systems are now introducing wider fields of view which have much greater clinical utility. 20 by 20 degree fields of view are quite easily achievable. It's now possible also to create full field 30 degree images, and this brings a real clinical utility to OCT angiography. Going forward, we need to be considering what do we do with these images, and what are the minimum standards for quantifying these images and producing accurate follow-up. And really now we're talking about using the highest possible resolution images that we can. So a resolution of 5.7 microns per pixel will allow us to visualize even flow in the smallest of retinal capillaries. If we're going to start to think about creating perfusion indexes or quantifying flow within tissue, then we need to be working at the very highest resolution if we're going to visualize all of the capillaries and therefore identify all of the flow. Follow-up examinations again require very precise follow-up, and we're entering a new era of follow-up examinations. Producing structural images that are consistent between examinations has been challenging, but we're now trying to record physiology. And blood flow varies with diurnal variation, exercise, and what effect does this have on our OCTA images and our ability to get repeatable evaluations. So eye tracking, image averaging, and noise reduction suddenly become essential tools when we're trying to perform OCT angiography. So what are the standards that we need to meet for OCTA systems going forward? We need a resolution that meets the minimum diameter of blood flow within retinal capillaries. The average diameter of retinal capillary is approximately 8 microns, the blood flow approximately 7 microns. So if we're going to record the smallest levels of flow, then we need a resolution of at least 5.7 microns to satisfy that requirement. For routine clinical utility, a resolution of 11 microns will suffice and will allow us to see the vast majority of flow within retinal capillaries and for us to make qualitative assessment of these images. The probability approach to OCT angiography allows us to create extremely high contrast images with a high degree of certainty of whether we're visualizing structure or flow. Eye tracking, again, is essential. Accurate follow-up is, again, an important part of the process and presents new challenges. We now have acceptable fields of view for routine clinical utility, and we need to more fully understand its comparison of OCT angiography to conventional dye-based imaging. And again, this is now possible using modern OCTA systems. Here we have an OCTA image of a normal subject. Within this image, we can see the obvious structural component of the image, and then a series of yellow dots which indicate the location of the flow. So we can get a correlation between structure and the location of the flow within the image. If I use this slider here, we can then just visualize the structure or just visualize the flow. And we're seeing two quite unique OCT signals, or merge the two together. Within this image as well, we can see a series of dotted lines which indicate the predefined segmentation for OCTA images. If I press F8 on the keyboard, we can then see the full image segmentation, no segmentation, or back to OCTA. So again, we can see where the flow signals are being derived from and how this relates then to the transverse section images that we're then looking at. Okay, we then go on to the OCT Angiography tab. We can now see four distinct windows. Top right is a transverse section OCTA image. Top left, a transverse section OCT image. We have bottom left OCT B-scan, and then bottom right OCTA flow data. If we use this predefined segmentation, we're gathering all the information from internal limiting membrane to anterior to Bruch's membrane. And this gives us all four vascular plexus within a single view. And this would be equivalent to the information that you would see in a conventional fluorescein angiogram image. A two-dimensional image of a three-dimensional vascular structure. Typically, we can choose to view superficial vascular plexus and then deep vascular plexus. And this again allows us to see two distinct capillary patterns. Or we can choose to subdivide that into four layers. We can look at within the retinal nerve fiber layer. On the en-face OCT image, you can see this arcuate distribution of the retinal nerve fiber axons, and the capillaries take on the same sort of arcuate distribution. Within the ganglion cell layer, we see the major retinal arterioles and venules, and also a very tightly looped capillary structure. The outer border of the inner plexiform, again we're seeing a fine capillary plexus. This is one capillary thick. And again at the outer border of the inner nuclear layer, again a single capillary thick plexus. And this time the capillaries take on a distinctly floret type appearance with a central hub or stalk. Within the avascular layers of the retina, this is going from the outer border of the inner plexiform to anterior to Bruch's membrane. We often see projection artifact. And this is one of the great controversies within OCTA as to whether or not this information should be removed. In applying suppression algorithms, you run the risk of removing important vascular flow in your attempt to take away the projection artifact. Now, clearly this is something that we need to work on as an organization and try and improve the appearance of this. And hopefully we'll be introducing this in the not too distant future. But until we're absolutely certain of what is being removed, we don't want to take away any projection artifact from the image. So we simply apply a little bit of human computing. You'll notice that in the en-face OCT image, we see a hyperreflective vascular pattern, and we see the same pattern as a projection artifact in the OCTA image. If we're seeing this change in both images, we see the vascular pattern in both images, we know we're looking at projection artifact. The OCTA, if we had a choroidal neovascularization, type 2 lesion anterior to the RPE in the avascular zone, we would only see the vascular pattern within the OCTA image and not in the en-face OCT image. So we can start to discriminate the differences. We'll look at that later when we start to look at some pathology. To visualize the choroid, we use some manual segmentation. So we use Bruch's membrane as a segmentation plane and create a slab that's approximately 20 microns thick, and adjust that to a position so it's just below the RPE. And now we can see the fine vascular mat of the choriocapillaris. We're unable to resolve individual capillaries, but we can see an impression of that vascular structure. Increasing the slab thickness slightly to approximately 30 microns, and then moving deeper, we can then start to see the vascular structure of Sattler's layer, and then deeper still of Haller's layer. So we can now start to visualize all of the vascular components within the eye. Okay, we'll look at a patient now with neovascular AMD. So when we look at the conventional OCT of this patient, we see a classic appearance of neovascular AMD. Subretinal fluid, shallow elevation to the retinal pigment epithelium, and subretinal hyperreflective material. Obvious signs of retinal thickening. When we look at the OCTA image, first of all look at the B-scan, and we can see an area where there's a very concentrated area of flow at the level of the RPE and just anterior to the RPE. So likely we're looking at a type 2 type lesion. When we look at the OCT angiography, one of the most rapid methods of assessing the image is to use a dynamic fly-through using adaptive segmentation. So what we'll do is take our segmentation program from the profile from the internal limiting membrane and change that gradually as we move down to Brooks membrane. I'll then use a segmentation slab that's approximately 60 microns thick. As I then move the slider, we can see the superficial vascular plexus, the deep vascular plexus, heading towards the avascular zone, and then we start to see our type 2 CNV, the classic sort of Medusa head pattern, and then as we move deeper still, we can start to see the type 1 occult component as well. If we look at the flow signal here, that correlates to this location of the green line, and we're seeing a high flow signal anterior to the RPE. If I then localize the position of the type 2 lesion, we can now see a flow pattern that's below the RPE. So we can be absolutely certain of the classification of the type of lesion that we're looking at. We can take the same sort of approach with retinopathic disease. So this is a patient with central retinal vein occlusion. The fundus image shows the classic appearance of dilated vessels, blot hemorrhaging, flame-shaped hemorrhaging, evidence of macular cystic change, and exudation. So a florid, acute central retinal vein occlusion. Again, if we take our same approach with the OCTA, we can start to use the same fly-through approach to evaluating the images. So once again, we'll go from internal limiting membrane to Brooks membrane, using a slightly thinner slab on this occasion. As we move the slab deeper, we can start to see the changes in the retinal nerve fiber layer. There's a lot of capillary dropout. As we go deeper, we see again lots of central macular ischemia. And as we move down again deeper, we can see dropout in the deep vascular plexus. If we look at the image on the left at the top, the en-face OCT image, we can now see the cystic pattern of formation that's present as we go through the retinal layers. When we're trying to evaluate OCTA images, it's important to understand where the signal is being derived from. So if we place our segmentation plane within the ganglion cell layer, we're seeing the pattern of the major arterioles and venules. We can see a large area of capillary dropout in the central fovea, but how much of this is actually ischemia and how much therefore is important information, and how much may be simply herniation of the vascular plexus caused by cystic change? Well, if we then reference the en-face OCT image, we localize one of the cystic areas, we see that this area here, there may be some capillary non-perfusion, but there's also evidence of cystic change, which is separating the blood vessels. Again, if we look in this location, more evidence of cystic change as we co-localize each one of those cysts. So in this location here, we're seeing the formation of a large retinal cyst. This causes herniation of the vascular plexus, or pushes the vessels apart, separating them, causing the impression of non-perfusion. If we click in this location where there's obviously, again, no signs of vascular flow, and then compare that to the en-face image, we see no evidence of cystic change. So we're absolutely confident in this location we're looking at capillary non-perfusion. Correlating what we're seeing in the structure with what we're seeing in the flow image is essential for us to understand and interpret what is happening with an OCT angiogram. And again, being able to correlate what we're seeing in the structural B-scan and determining where the location of the flow is located tells us whether we're looking at superficial or deep retinal changes. Finally, we look at a patient with proliferative diabetic retinopathy. Again, the color image shows us classic signs of proliferative retinopathy. We can see neovascularization elsewhere. there's evidence of historical laser treatment, multiple dot hemorrhages and microaneurysms, but the central macular region is relatively spared of clinical features and looks relatively normal. Certainly no evidence of gross exudation or microaneurysms. Again, those are clinical signs that we may be looking at ischemic change. So when we start looking at the OCTA image, again, we should get a clear indication of what is happening. And once again, we're seeing evidence here of capillary non-perfusion when we're looking at the superficial vascular plexus. We can see an irregular foveal arcade. It's only intact at this location. In these locations, we're seeing irregularity and extension of the foveal avascular zone. There are obvious signs of non-perfusion. Again, if we click in this location, compared to the appearance of the en-face OCT image, there's again no evidence of cystic change, so we can be confident that we're looking at capillary non-perfusion. Again, if we look at the deep vascular plexus, again, there's extensive signs of capillary non-perfusion, an enlarged foveal arcade, and once again, evidence of non-perfusion and no evidence of cystic change on the en-face image. Again, being absolutely sure and confident that we're visualizing ischemic change. One final patient. Again, this is a patient with a rather unusual appearance, a patient with an adult vitelliform lesion, which has ended up with secondary choroidal neovascularization. Again, we've got subretinal hyperreflective material. You can see the level of the retinal pigment epithelium on the B scan. Looking at the OCT angiography image, again, allows us to get a clear indication of where the changes are occurring. Within this reflective area here, there's clearly a high level of flow. So then when we look at our OCTA image, we should be able to identify the location of that change. So again, using the fly-through approach, again, thickish slab. As we scroll through, we get a normal superficial vascular plexus, deep vascular plexus. And as we move into the avascular zone, we're starting to see an area where we're getting a separate vascular structure. As we move deeper, it becomes a more extensive lesion. We're starting to see this classic hypoflow signal around the lesion. A little bit deeper, and we can start to see an occult component. If we adjust the contrast now, we can now visualize the extent of the vascular network much more effectively. Selecting Brooks membrane as a segmentation plane and slightly thinner slab means we can be slightly more precise. As we move superiorly, we can see the superficial component of the lesion moving downwards. We start to appreciate the full structure. And as we go below the RPE, we can start to see the extent of the occult components. So again, within neovascular AMD, we're able to be much more confident about the location of the flow, the shape and structure of the choroidal neovascularization, and its relationship to the anatomy of the eye. So we can get a strong and confident evaluation of the type of lesion we're looking at. I hate to say probably better than we could do with conventional dye-based imaging. That's probably a controversial statement. In conventional dye-based imaging, all we would probably see within this lesion is a large area of hyperfluorescence. Unless we're very fortunate and we're able to capture very high quality early phase images, we wouldn't see this kind of vascular structure with this degree of clarity. OCT angiography images are required as part of a standard volume scan of the retina. Essentially, we're doing really nothing different from a conventional OCT scan. The density of the scan is much, much higher than would be normally required for routine structural assessment. At each B-scan location, multiple scans are required and all bulk movement is removed from the images. We're then comparing each B-scan, looking for change within that, which would indicate the movement of red blood cells within the capillaries. The amount of data that's being acquired in an OCTA scan is much, much higher than in previous OCT examinations. The typical file size is about 600 megabytes. The typical amount of data in a high-resolution OCTA scan is equivalent to a chest CT scan. I think we are facing a new horizon in terms of ophthalmic imaging, whereby we need to start to address the ongoing concerns of storing large amounts of data for long periods of time. And perhaps there are lessons to be learned from our medical colleagues in radiology. The question I'm often asked is, will fluorescein angiography and ICG angiography be replaced by OCTA imaging? It's very difficult to be say for sure, but the introduction of OCT imaging has reduced our reliance on dye-based imaging. The introduction of OCTA inevitably has to have the same effect. But will it actually ultimately completely replace dye-based imaging? Probably not for the immediate future. The immediate utility for OCT angiography, I think, will be in microvascular disease of the retina. So we're looking at diabetic retinopathy and retinal disease. It immediately seems to have a clinical utility for diagnosis of neovascular AMD. In terms of retinal disease, we're talking about retinal vein occlusion, also possibly arterial occlusion. At the moment, there is very little that we can do in terms of treatment for arterial occlusion, but for venous occlusion, there are clearly indications where angiographic assessment will change the outcome in terms of the treatment for the patient. In terms of treatment monitoring, one of the questions we have in both retinal vascular disease and diabetic retinopathy is there an ischemic component to the patient's vision loss? And clearly, OCTA provides a non-invasive way of providing that information to the clinician. In terms of treatment monitoring for neovascular AMD, I think we still need to understand more about what is actually happening to these lesions following anti-VEGF therapy and how we're recording these changes with OCTA. And until we have large randomized clinical trials that look at OCTA as part of the clinical outcomes, we will not be sure as to exactly what its utility will be in follow-up examination. But clearly I think it has a role, and its non-invasive nature makes it extremely appealing to both clinicians and researchers. Clearly there is a lot of interest from primary care practitioners in terms of using OCTA in a community setting. The non-invasive nature of the procedure is clearly appealing, but until we fully understand its clinical utility, it's probably too early to say what its role will be. Certainly it has a place in early diagnosis, and it may very well have a place in treatment monitoring. So therefore, as part of a shared care scenario, you could possibly see OCTA angiography having a place within a community practice. What is the advantage of OCT angiography? We can start to visualize all four vascular plexus within the retina, and therefore we can start to unlock the complexities of some of the diseases that we're routinely assessing. Up until this point, the only way of assessing the microvasculature of the retina has been using fluorescein angiography, where we see a two-dimensional image of a three-dimensional vascular structure. With OCTA, we're able to separate out all four vascular structure and perhaps see how different diseases affect these vascular plexus, and also how treatments ultimately have an impact on the flow within these tissues. That's one immediate advantage. We're also getting a structural component with OCTA. So we can isolate the flow, we can visualize the structure, and we can then start to get a flow-structure correlation. And again, this starts to unlock our understanding of the pathophysiology of a lot of diseases. The disadvantages of OCTA at this time are still relatively small fields of view, the size of the files that are being generated, and at this time we struggle to identify areas of leakage or staining or pooling which we would normally visualize within a dye-based image. Therefore, we're having to use other surrogates for evidence of leakage. So the presence of intraretinal cysts, subretinal fluid, thickening on an OCT map, or using high-resolution fundus imaging to provide information regarding the location and presence of exudate. So what is the place of OCT angiography in an optometry practice, and should an optometrist invest in this technology? At this point in time, I think it's very important to remember that we're looking at an embryonic technology, and our understanding of its clinical utility and its clinical application is still evolving. Consequently, it's probably too early to make that investment. Having said that, the non-invasive nature of the test means that it's very, very appealing to the high street practitioner. And therefore, in the future, it may very well have a place as an early diagnostic tool. And certainly as part of a shared care model, it certainly would have clinical utility. I'm often asked questions about the difference between spectral domain OCT and swept source OCT. Essentially, these technologies are very, very similar and provide very, very similar information. So simply different ways of skinning a cat. If we're thinking about spectral domain OCT, we're using a wavelength of light typically which is around about 880, 890 nanometers. And this provides optimum resolution within the neurosensory retina. And this is where we're spending most of our time assessing structure. Certainly with swept source OCT, it's possible to visualize more information in the vitreous and the choroid, but there is a price to pay. By using a longer wavelength laser, we get a lower resolution within the retina, and we also get a lower signal-to-noise ratio. With modern spectral domain OCT systems, we're getting performance curves that are very, very similar to swept source OCT devices. So really, there is no difference between the technologies. It's simply a different way of achieving the same end result. SD-OCT is optimized really for chorioretinal imaging. It provides extremely high resolution results and is much more predictable in terms of image quality. It also potentially is much faster than spectral domain imaging. It's a parallel detector, and therefore we can record more information more quickly. The advantage of swept source OCT is it gives you a more consistent signal across a greater depth range. So for whole eye imaging, it has an immediate application, and for anterior eye imaging, again an immediate application. Here, the depth of scan is more important than the resolution. The technology is often seen deployed now in biometry systems, where we're making measurements of axial length, corneal curvature, corneal thickness, anterior chamber biometry, and lens thickness measurements. In this situation, swept source OCT most definitely has an advantage. Swept source OCT is not necessary to visualize the choroid. Simply controlling the depth of focus of an SD-OCT system allows you to visualize information in the vitreous, retina, and choroid simply by changing the focus of the OCT system. There is no doubt that swept source OCT will open up new opportunities in terms of imaging, but it's not in terms of imaging structure or in OCTA where we'll see those advantages. Is swept source OCT necessary for OCT angiography? Well, the simple answer is no. High resolution OCTA images can be generated using SD-OCT platforms, and there is no advantage particularly to using a swept source device. So thank you for your attention.